Hi, I'm Matthew Holt. This is our THCB Spotlight, and I'm talking today with Katherine Saunders. Katherine is an MD who is the co-founder of FlyteHealth, which is in the obesity space. I suspect she hangs out with a lot of people like me. Need to go on a diet and figure it all out. Catherine, uh, obesity medicine, right? Something that you're a specialist in and have been working on for many, many years. I know you did a fellowship in it and all the rest of it. Become very trendy in recent years to figure out what we're going to do about this. For 35 years, as well, I can tell America basically ignored it. And then all of a sudden, we've seen in the last decade and a half, a lot of different sort of ways to start thinking about it beyond kind of what Weight Watchers did. So first things first, tell us about why you decided to go into the startup business to deal with this rather than just work as a clinician. I'm not saying you're not working as a clinician, but why a startup rather than just becoming an obesity specialist, as there are many in America?
Sure. Well, Matthew, thank you so much for having me. I'm really
Oh,
excited to be here with you today. Um, yeah, so I got into the field of obesity medicine right out of medical school. When I was in medical school, my mentor, Dr. Lou Aroney, gave a talk about obesity, and none of us had learned anything about obesity in medical school. I knew then that I wanted to go into this, but at the time, everyone was like, "What are you going into? Why do you want to be a diet doctor? What's obesity?" It was just so early on. And then I did a fellowship at Cornell, while Cornell, where I did all my medical training. After my fellowship, I joined the faculty, and I very, very, very quickly had a very long waiting list. And at the time, my husband, who is the more entrepreneurial one, although now we are both entrepreneurial. He recognized the tremendous, tremendous opportunity to help so many more people. At the time, he said, "Oh my gosh, you guys have this deep expertise that, very, very few healthcare professionals have, and millions of people need your help. And there's so much more we can do." At the time, I was one of the first 20 fellows in obesity medicine in the entire country. I was the first at Weill Cornell. And my mentor, Dr. Lou Aroney, was one of the pioneers of the field. And so, we were in a smaller group of providers who really knew how to do this. And we were doing it really well. And so, after a couple of years of practicing at Cornell at the faculty practice, we teamed up with Dr. Roney and started the company to really scale and democratize access to the kind of very high level, very effective medical obesity treatment that we were delivering.
I like the idea. Not an uncommon one. Instead of touching the maximum number of patients you can touch during a day or a year, you can touch many more if you can figure out how to scale it. Obviously, there have been many, many attempts to figure out how to deal with obesity, and if you just look at the numbers, they haven't made a lot of impact. En masse, I'm sure they've made individual impact, but we've had Weight Watchers and a bunch of diet sites around for forever, and Americans have got fatter and fat. Well, more and more Americans have become obese over that time. Everyone talks about, oh, you go back to Europe, you lose 20 pounds just eating the food, and you come back here and you put it back on. And I must admit that's happened to me a couple of times. Um, I guess the question is, what works that you want to scale on the sort of how to managing obesity? There's a lot of different things. Obviously, we have these drugs you may have heard of called GLP-1s. We have different types of surgery. You have obviously different types of programs. You have the sort of typical Weight Watchers approach of weigh-ins and sort of community support. What works?
Yeah, great question. First of all, it's really important to kind of take a step back and recognize that, obesity used to be considered just sort of a lifestyle problem, that people were eating too much, exercising too little, and that was it. And so the
But Can I
solution.
can I ping you there? People are eating too much and exercising too little, right? I mean, that's not a myth.
Well, but we know that it's much more complex. We know that there's a huge genetic component. We know that obesity is a disease because there are dysregulated hormonal pathways that drive people to eat more. And so it's not just eating too much, exercising too little. It's everything that kind of leads to it and then what propagates it. I actually recently did a TED talk that explains the whole science behind obesity. So that's a good place to kind of.
We'll link to that in the notes, but good.
Perfect. So that's a 11-minute overview of why it's so easy to gain, hard to lose, why it's a disease. So it's important to recognize that obesity is a serious, heterogeneous chronic disease. And for most people, just being on a diet and exercising will not lead to significant and more importantly, sustained weight loss. So if you take a look at the very, very, very best lifestyle programs, the average weight loss is about 3 to 5%, which is a little bit, but not generally enough for people to improve health outcomes. And then when you take a look at what happens after that initial weight loss, 80% of the weight is generally regained within 5 years. So lifestyle interventions in and of themselves do not work in a significant and sustained way for treating obesity. And so oh, go ahead.
I was just going to say, whenever I've lost any weight, regaining it within 5 years, more like 5 minutes, but there we go.
Yep. Yes. Well, we can definitely talk after this interview about other effective treatments. But so your question is, what works? And what works is really figuring out, what does somebody with obesity look like? Everybody has a different version of the disease, and so understanding what has led to their obesity and what has prevented that person from treating their obesity, first of all, is the most important step to just do an evaluation and figure out like what is going on. And then once we do that and address everything that can be addressed, we optimize dietary strategy, optimize physical activity, and then we treat medically. And so that's where medication, surgery, other, advanced treatments come into play. And that's what's really needed for the majority of people with obesity to treat their disease effectively.
Okay, so give me some rough breakdown percentages about who buckets into which category. You mentioned can we get people eating right and exercising, which like it's really hard. Everyone knows that that kind of behavior change is really hard. Then figure out about other stages of interventions. So roughly, if I want to give, I want the funnel. Roughly, who gets referred into Flight Health? What level of obesity, how much overweight? I don't know how you define, who you need to start treating, and then of those, how many can you manage with diet and exercise? How many do you need to get into medical treatments, and what kind of treatments are you using?
Yeah, the numbers are very easy. By the time most people see an obesity specialist like me or come to a practice like Flight Health, they've tried and failed everything and nothing is working. And so we only see people who have obesity or have overweight with medical complications of their weight. So we don't see people who have normal weight and they're trying to lose 5 pounds. We only see people who are really good candidates for medical intervention. And because most people have tried and failed a million things over the years, um, I, you know, 99% of them are very good candidates for medical treatment like a medication. So, it's very rare that we see a patient who's never tried anything. If that's the case, maybe we would, do a couple months of, some sort of lifestyle intervention before starting medication. But, the guidelines really recommend starting medication off the bat because it's not that the treatment is to treat the underlying disease. The diet and exercise are more important for health and less important for weight loss. It's really the medical treatment of the disease that leads to significant and sustained weight loss.
Okay, so let's talk about what Flight Health is doing. First off, describe, who you are selling the service to, who the end payer is. How do people find you, as opposed to finding a random obesity doctor if they could do that, or ending up looking for some weird thing on online, which gives them, pills that America's frontline doctors are selling them for weight loss and, deworming or something. There's a lot of that going on. How do they find you? And then what is the process like for a patient when they come on board?
Sure. So we mostly work with employers and health systems. So for example, we'll talk about this a little later, but the state of Connecticut is our largest employer. We also work with other employers around the country, and we work with a number of health systems. And so if someone is an employee of a company that works with us, they are able to see us as part of their employer benefits. If someone is part of a health system that works with us, same thing. It's part of, what is their program and what are their offerings. We do see many people who come to us directly. We still, have so many referrals from our Weill Cornell network in New York City. And so we're in network with many plans in New York, Connecticut, New Jersey, and we're in in all 50 states, but we may not necessarily be in network in all those 50 states unless there's a reason for us to get a network. So people find us mostly from their employer, from their health system, and sometimes directly. We have tons of referrals from, patients who've done very well. Their friends, their family members, their coworkers all will, come and seek out the same kind of care.
Okay. So they arrive somehow. It's a covered benefit. So I don't know what the level of costs are, and I assume there are different benefit structures. But what happens next? So now I'm on the intake. How do you go through the process of this is mostly this is all remote, I understand. So how do you go through the process of figuring out um, who needs what? What is the process? What is the patient evaluation part?
Mhm.
Who's
Yeah.
doing it? How much is automated? How much is humans? What kind of humans? Take me through the process.
Yeah, great questions. So we basically function like a very, very high level medical practice. When we first see a patient, they have gone through a pretty extensive intake process where they have to submit a large panel of labs. If they've had labs done in the last year that, satisfies what we need, wonderful. Otherwise, they go to a lab, have the labs done. They also fill out a series of questionnaires or a health risk assessment so that we can have a good understanding of their medical history. So similar to, going to a new primary care doctor, where the primary care doctor needs to know everything about you in terms of labs, in terms of your overall health. That's the information that we require people to provide to us before we see them. And then our initial visit with them, it's either a medical doctor, an MD, or a nurse practitioner, an NP, who does that initial assessment. And we spend an hour with our patients. And the purpose of that initial visit is really to understand the version of that person's obesity so that we can get all the information we need about every single factor that has led to the patient's obesity and every single barrier that has prevented them from treating their disease effectively. Once we get all of that information, then we do a lot of education. We explain to patients, this may feel like you don't have the willpower or that this is your fault, but it's not your fault. It's not a matter of willpower. This is a disease, and here's why it's a disease, and here's what your disease looks like. So we'll explain, you have a genetic susceptibility. 40 to 70% of obesity is heritable. And we will go through all the contributors. So many people have undiagnosed sleep apnea. Many people are on several medications that are causing weight gain. So we'll address all of that and explain it to the patients. Then we talk about optimizing, everything lifestyle wise. So dietary strategy, physical activity, behavior, and then we will talk about advanced treatments. And we don't jump straight to a GLP-1 for most people because there are so many obesity medications, and because we have, our team is all medical experts, obesity experts who can use all of the tools, not just prescribe a GLP-1 to everybody. We end up prescribing, in a risk benefit, way where we prescribe more conservative approaches first and then escalate to a GLP-1, if and when we need to do that.
So I've got whatever treatment I've got, maybe a medical one. I don't know if you refer out to surgery, bariatric surgery, and that kind of stuff as well.
We do. Mhm.
But I assume you're not doing that over telehealth.
Mhm.
My buddy Roger Agarwal used to do this at he used to do this at Jefferson, and then somehow quit that high-paying lucrative job and went off and started his own startup. He probably needs psychological counseling, which maybe we can provide later. Um, but what what happens next to the patient? So they meet with that first one. That's
Yep. So they have that first initial visit. We start them on a treatment plan.
yeah.
And then we have a cadence of visits. And it's really it's a care team that's necessary for really good care. So they have their prescribing provider, an NP or an MD or both, and then also a dietitian. And so they have touch points with, one of their providers basically every month. And it's that first several months that are pretty high maintenance. So they are meeting with one of the providers on our medical team basically every month to assess their progress. So if things are not working and we need to change course, we'll do that. We don't want them waiting months and months and months and not making any progress. If they're, if they have questions, if they have side effects, if they have any issues, we tell them, to get in touch with us between visits. But we have so many touch points at first to really fine tune what we're doing so that we're able to, minimize side effects. We're able to really personalize our dose titration in a way where we can help people get to their health goals before we then transition to the phase of weight maintenance. So those first few months are a little bit more high maintenance. Patients are checking their weight, their blood pressure, different metrics in between visits so that we can monitor them and see how they're doing. And then we just continue to adjust until we reach their health goals.
Okay, a lot of stuff going on in there. So number one is how do you work with their primary care doctors if they have them? Basically, are you their primary care doctor for now?
No, no, no. I do not do primary care. We make sure at our initial visits that every single patient has their own primary care doctor because we don't do primary care. What we do is very specialized in terms of treating obesity. But obviously, we affect blood pressure and thyroid, and so we manage a lot of other conditions. But everyone has their own primary care doctor, and so we communicate with people's primary care doctors so that we keep we have open communication and, we have, it's really important for us to have those relationships as well.
I understand that. That's a thing. Everyone says they want to do that, but in general, that works very poorly in American healthcare. So what have you done to try to make that work better?
Yeah, so we send our notes to their primary care doctors. We make sure that we have a primary care doctor for every single patient, either before they come in or we make sure that they have one. And so we send our communications back and forth. And then if there's a need for them to reach out to us, they know that they can do that anytime, or we'll reach out to them if there's something that we need to connect on.
Okay. So let's get to the interesting part. Does it work? What
Yeah.
happens? What happens to the patients who come to you, and what are the sort of results you're seeing? And then, I'm saying what happens is how many of them end up on GLP-1s, how many of them get referred out to bariatric, how many are on other drugs, and then what's the typical result that you expect to see?
Yeah, so I think what really differentiates us from other solutions out there is that we have so much expertise that we're able to really customize our treatments and figure out really personalized treatment plans so that we don't just depend on GLP-1. So many of our patients never even require a GLP-1. We have huge percentage of patients who lose all the weight they need to lose to achieve their health goals on one generic medication, two, three, four, our expertise is really in combining those medications to get excellent results. Then a certain percentage of our patients are on GLP-1s and, either they have a reason why we prescribe those off the bat or they're not responding to other treatments. And so we get really great results. Obviously our patients lose more weight on average if they're on GLP-1s just because they're more powerful, effective meds. But our weight loss numbers for patients who are not on GLP-1s are very, very, very good as well. And in addition to the weight loss, our goals are really health outcomes. So improving or resolving weight-related health complications, and also greatly reducing the risk of developing other health-related complications.
So can you give me some numbers about how effective it is on how many patients that you've seen? Give me
Sure. Yeah, absolutely. So, the state of Connecticut is a population where many patients come to us after receiving care elsewhere or they've already lost weight elsewhere. So it's a very heterogeneous population. Many of them have many weight-related comorbidities, and many of them have already lost weight. So we're not starting with a population like in clinical trials. So we are able to get, over 16% total body weight loss on average, looking at patients on GLP-1s and patients on generic medications.
Okay, so that sounds pretty effective. What's the average percentage that someone needs to lose to get to their goals in your population? around
Yeah,
that?
that's a great question. It's really all across the board. It totally depends, what medical complications people come to us on. If you take a look at, data, we used to consider 5 to 10% really clinically significant or sufficient for significant weight-related health outcomes. Now, because it's so much more achievable to help people lose 15%, 20%, 25%, those are the new goals, but we really customize it. So I would say, everybody loses more than 5 to 10%. And then above that, it just really depends on their bodies, their medical conditions.
That's great. So I've got two questions for you that are relevant. So the first one is this is quite an intense process that you're talking about, quite a lot of humans on your end. Your goal here was to scale this to millions of people, right? Other than hiring more and more obesity specialists and dietitians, right? How is this different other than it's telehealth virtually in person than what you're doing at Well Cornell?
Yeah, great question. You're right. When we started our company, we were a SaaS platform. So we started with software. And so our software basically enabled other providers to provide this kind of care. So our goal was to empower existing infrastructures to democratize and scale. We very quickly found out that most health systems did not have providers who had any bandwidth to take on one more thing. And so we ultimately ended up, starting our own clinical services that are powered by our software. So basically, we have the software as a standalone. So we use our software with health systems so that they can provide the care themselves. So that's a way of scaling. But then we also use technology. We have patented algorithms. We have, a whole program that's been studied in clinical trials that powers our ability to provide care at the highest level of our degrees and to save us as much time as possible on, anything that we could be doing that could be automated, that could be, data that patients provide us in advance that, so we are using technology to enable us to see as many patients as possible, even though we definitely have a large team of healthcare providers.
Yeah, you managed to say that whole sentence without using the phrase, without using the two letters AI, which was very clever. But I mean, that this does seem to be one of those questions where, and by the way, you enabled me to use the buzzwords of AI and GLP-1s in the same interview, which is very cool. Does seem to be an opportunity where, much like I see there's a lot of counseling going on here and a lot of sort of nutritional counseling and stuff. I mean, how much of that is, do you think, over the next 3 to 5 to 1 to 3 to 5 years, whatever the numbers are likely to be, able to be to translated to take your nutritionist, your people out of the program and put in AI type avatar slash other information like that.
Yeah, so it's interesting as we're able to do so much more with machine learning, with AI, with all of this technology, it still doesn't replace the relationship with a care team, and especially with obesity medicine. It's Obesity is really tricky. It's a really hard disease to treat, and it's a hard disease to treat well, and it's a hard disease to treat long term. So we never anticipate, completely replacing a dietitian or completely replacing a doctor or a nurse practitioner. But again, you're using technology as much as we possibly can to take away any aspect of our treatment that, or we don't need that relationship. We don't need the personal touch, where we're just kind of collecting data and making, medication recommendations to providers. So it's not an area where we're going to see as much replacement of providers.
But can you give me an example about what kind of thing are you using? Are you helping your providers by giving them whatever with machine learning or AI? Give me a
Yeah, sure. So we have patented algorithms that we created when we first started the
right.
company, that basically take in health data, take in labs, take in everything that we can feed it and make recommendations. So for someone like me, I can, do this in my sleep. I don't need that. But for providers who haven't been doing this for so many years and need, more hand holding, the algorithms basically give all the recommendations to the patients and then another set of recommendations to the providers. And specifically where our real, IP lies is in the medication decision support. So we have the technology that will say, consider these medications, use these medications with caution, and do not use these medications. And then we have technology that, follows and makes recommendations as patients go on.
Okay, so essentially you're talking about upskilling the kind of practitioners you currently have on the upskilling and improving their advancing their level of understanding as quickly as possible. So I mean that there is some scale there. I'll agree with that. Okay, last couple of questions. You may have seen or heard that there are people selling compounded GLP-1s. A lot of people are, we've obviously the other big fuss about do they work, and clearly they work, and are there side effects and all that kind of good stuff, and should we invade Denmark? The other question, well, apparently we're going to invade Greenland. Why are we going to invade Greenland when the valuable part of Denmark is Copenhagen? I don't know, but that's we will refrain from discussions about our president this morning. But the big issue is the cost, right? Which can vary and can be $1,200 a month, whatever, for GLP-1s. You can buy the compounded stuff for now from online pharmacies for a lot less, a few hundreds a month. How do you charge both for your services, or what do you charge your employees for your services, and when they're getting GLP-1s on top? How does that work out cost-wise? And then, what is your sense about how this is playing out, given, the ongoing costs of GLP-1s and whether they should be used permanently or whether you can taper them off? Just talk to me a bit about the sort of the cost-benefit effect and how we are for the more expensive drugs, how you're thinking about it.
Yeah. So we go through insurance. Our mission as a company is really to democratize access. And because this is, chronic disease management, long-term management, we don't want this to be expensive for the individuals. And so when somebody comes to see us and we're in network, it's just like going to see a doctor. We're in network. They don't, they pay a copay to see us, and then we prescribe medications, and we work very hard. We have a large team of people who do prior authorizations, who do appeals to get, medications covered. If someone comes to see us through their employer, then it's no charge to them. It's an employer benefit. So the employers pay, per engaged member per month. So that, and then when we have employer customers, we still prescribe medications that go through insurance. So everything we want to be as easy and inexpensive for the patients as possible. Of course, we definitely have situations where we just cannot get a medication despite, tons of, appeals and everything that we try to do. We just can't get what we want for patients. And so, there's still spotty insurance, and then, high prices and shortages. There's so many barriers to patients getting what they need. So we do our best and we're really handy, but it's also just important to understand that, like, it's not just about GLP-1s. Like, if we can't get a GLP-1, we have tons of backup plans of medications that we can get, and we have the expertise to be able to get great results with non-GLP-1 medications.
On the GLP-1 front, are you seeing a lot of different, broadly speaking, is it getting worse or getting better in terms of getting access to that? My impression is that there's more and more plans and employers are trying to cut it off rather than, and then the second part of that question is what happens if somebody's been on it for a while and they have to go off what does that do to their results?
Yeah, so I mean, we're seeing states and we're seeing employers all over the country that have rescinded coverage, which is really, really horrible for the employees and for patients because, we know they're going to regain some or all of their weight that they've lost. So it's really, it's not a good situation to have coverage and then lose it. And so what our differentiator is that, companies and states that have had to do that, looking to us as in our model with the state of Connecticut, we can do this in a way that's much more cost effective so that they don't end up overspending and rescinding coverage. It's better to be, more conservative on the front end. Like everyone says, oh, just prescribe GLP-1s and then deprescribe or get people off. But that one doesn't work. And two, it makes so much more sense to have a stepwise approach on the front end. So we only have patients on GLP-1s who really need to be on GLP-1s. To answer your question about what happens if people need to come off, it's really hard. It's not a good situation. And it's something that, we all face because people lose insurance, there are shortages, so many different things can happen right now. And it's really not ideal. So what we do when our patients lose coverage for any number of reasons is, we switch them to alternative treatments. And again, because we have the expertise to really, prescribe other meds other than GLP-1s very well, we're able to make sure that patients don't regain all their weight.
What do you think about the compounded GLP-1s? Do you think they're safe to use? I mean, because those are much closer in price to what somebody can manage out of pocket. They're not cheap, but you could probably do 2 to 3 grand a year. You probably can't do 12 to 15. So, what do you think that's a viable alternative? I mean, we're seeing a lot of companies really pushing that very hard, and we know there's issues with whether there's a shortage or not, or whether it's safe or not. And Eli Lilly coming after people for their patient records, and all kinds of weird stuff. But I mean, do you think that's going to be a longer term alternative?
I have big concerns about the safety of
Okay.
compounded products. So we as a company will never do that.
All right, cool. All right, let's tell me a little bit about the company you mentioned. I know you raised was it $7 million last year, the year before last, sometime relatively recently. Tell me a bit about that. You started in 2019. How much money you raised? How big you are? How many patients you treated? Just give me a flavor. I know we talked about the state of Connecticut, but give me a flavor of where you are as an organization.
Yeah, sure. So we are just about to raise our Series B. So I feel very fortunate to have gotten to the stage of Series B. It's very exciting. I think we have about 100 or so employees at this point, and we've seen over 10,000 patients since we started.
All right, well, that's a decent number. And how much did you raise in eight? Was I right? Was it 7 million?
I think it ended up being closer to about 16,
Oh,
actually.
so,
We when
bit like
we
my weight when I get on the scale, I'm only 7 pounds overweight. Oh, hang on, I'm 16 pounds overweight. Yeah, well, okay, that's great here. So you raised a bit. You're out raising some more at the moment. You said all the Series B is in process at the moment. Um, and give me the last thing I want to ask you is sort of there is a big panoply of companies in this space, right? So we talked originally about, the diet sites that were online, and obviously the modern version is selling the GLP-1s compounded. You've got people like Amada and various parts of Livongo and others who've been doing this for a while. Inside, you've got a bunch of other people playing around in the obesity space, and then you've got the old classics like Weight Watchers. Um, how do you think this plays out? I mean, what do we end up with a few big players in this space, and that they take a very medical approach like yours in extreme situations, and they either refer to you or they buy you or whatever? What do you think that the landscape of obesity companies looks like in a few years' time?
Yeah, I think that's a great question. And different things work for different people. And so, millions of people have obesity. So there will always
No
be
shortage of demand, is my understanding. Yes,
no shortage of
I've been to
demand.
Disneyland. I've seen it.
No shortage of demand. But I think you're right. I think we are going to see some consolidation in the space just because there's so many different solutions out there.
All right. Very good. Well, I've been speaking to Dr. Katherine Saunders. She is the co-founder, chief medical officer, and bottle washer at FlyteHealth. Katherine, thanks for your time.
Thanks so much for having me, Matthew.